Here's the organized and highlighted summary of heart murmurs and auscultatory findings in different valve diseases. Systolic murmurs, aortic valve stenosis, crescendo decrescendo systolic murmur, heard at the right upper sternal border, radiation to the carotid arteries. Pulmonary valve stenosis, crescendo decrescendo systolic murmur, best heard at the left upper sternal border, associated with a systolic ejection click that increases with inspiration, radiates to the left clavicle. Mitral regurgitation, holosystolic pansystolic murmur, heard best at the apex, radiates to the axilla or precordium. A systolic click may be heard if there is associated mitral valve prolapse. In acute severe mitral regurgitation, a holosystolic murmur may not be heard. Tricuspid valve regurgitation, holosystolic pansystolic murmur at the left lower sternal border, radiation to the left upper sternal border. The murmur will increase with inspiration. Atrial septal defect, systolic crescendo decrescendo murmur, heard at the left upper sternal border, associated with a fixed split S2 and a right ventricular heave. Ventricular septal defect, holosystolic pansystolic murmur at the left lower sternal border, associated with a palpable thrill, increases with isometric hand grip. Diastolic murmurs, aortic valve regurgitation, diastolic decrescendo murmur, heard at the left lower sternal border or right lower sternal border when associated with a dilated aorta. Pulmonary valve regurgitation, diastolic decrescendo murmur at the left lower sternal border, mitral stenosis, diastolic low-pitch decrescendo murmur, heard at the cardiac apex in the left lateral decubitus position, associated with an opening snap, tricuspid valve stenosis, diastolic decrescendo murmur at the left lower sternal border. Continuous and combined systolic diastolic, patent ductus arteriosus, severe coarctation of the Here's the information you provided about the differential diagnosis for acute dyspnea, organized and highlighted for easy reference. Acute dyspnea, differential diagnosis. Cardiovascular causes, CF, congestive heart failure, ischemic heart disease, acute myocardial infarction, pericarditis, cardiac tamponade, arrhythmias, valvular disease, congenital heart disease. Pulmonary causes, obstructive lung diseases, COPD, asthma, bronchiectasis, PE, pulmonary embolism, ARS, acute respiratory distress syndrome, pneumonia, TB, tuberculosis, bronchitis, pleural effusion, pulmonary edema, pneumothorax, upper airway obstruction, foreign body aspiration, ILD, interstitial lung disease, chest wall abnormalities, kyphoscoliosis, rib fracture, ankylosing spondylitis, psychiatric disease, generalized anxiety disorder, panic attacks, hyperventilation, hatch systemic causes, severe chronic anemia, sepsis, DKA, diabetic ketoacidosis, GERD, gastroesophageal reflux disease, medication, narcotic overdose, neuromuscular diseases, diseases that weaken respiratory muscles, myasthenia gravis, muscular dystrophy, Certainly, here's the text from the image you uploaded, organized with bold headers for easy reading at a glance. Chest pain, differential diagnosis, non-cardiovascular disorders, costochondritis, differentiating features, pain exacerbated with inspiration, reproduced with chest wall palpitation. Hiatal hernia, differentiating features, reflux of food, relief with antacids. GERD, differentiating features, acid reflux, relief with antacids. Peptic ulcer, differentiating features, epigastric pain worse 3H after eating. Gallbladder disease, differentiating features, right upper quadrant abdominal pain and tenderness at hash. Cardiovascular disorders, myocardial infarction, differentiating features, pain more severe, usually 20 min in duration. Aortic stenosis, differentiating features, typical systolic ejection murmur, myocarditis, differentiating features, pain is usually vague and mild if present. Pericarditis, differentiating features, pain is sharper, pain worse with lying down and relieved by sitting up. Dissecting aortic aneurysm, differentiating features, pain is sharp, tearing, often occurs in back. Mitral valve prolapse, differentiating features, transient pain, mid-systolic click murmur, and young female with no risk factors. Pulmonary disorders, pulmonary embolus infarction, differentiating features, tachypnea, dyspnea, cough, pleuritic pain, hemoptysis. Pulmonary hypertension, differentiating features, signs of right ventricle RV failure. Pneumothorax, differentiating features, sudden onset of pain and dyspnea. Here's the diagnostic algorithm for a patient with chest pain, organized with bold headings for clarity. Patient with chest pain, diagnostic algorithm, rule out any life-threatening causes. These include acute MI, USA, unstable angina, aortic dissection, pulmonary embolus, tension pneumothorax, esophageal rupture. Assess vital signs. Develop a focused history. Character of the pain, pressure, squeezing, tearing, sharp, stabbing, etc. Location of pain, severity of pain, duration of pain, setting in which pain occurred during exertion, at rest, after meal. Radiation of pain, aggravating or alleviating factors, e.g., meal, exertion, rest, respiration. Does the patient have a cardiac history? Ask about results of previous stress tests, echocardiograms, cardiac catheterization, or of any procedures, PCI or CABG. If the patient has a history of angina, ask how this episode differs from previous ones, more severe, longer duration. Perform a focused physical examination with attention to cardiopulmonary, abdominal, musculoskeletal examination. Order ancillary tests. Obtain ECG in almost all cases. Cardiac enzymes, CK, CKMB, troponin, depending on clinical suspicion. Obtain chest radiograph, CXR, in almost all cases. Under appropriate clinical setting, work up the patient for pulmonary embolism, PE. Develop a diagnosis. Certainly, here's the information on diagnostics of peripheral edemas, organized with bold characters for easy reading. Diagnostics of peripheral edemas. History. Include the timing of the edema, changes with position, and if it is unilateral or bilateral. Medication history. Assessment for systemic diseases. Physical examination. Assess for systemic causes of edema, such as heart failure, jugular venous distension, crackles, renal disease, proteinuria, oliguria, hepatic disease, jaundice, ascites, asterixis, thyroid disease, exophthalmos, tremor, weight loss. Evaluate edema for pitting, tenderness, and skin changes. Laboratory and imaging tests, brain natriuretic peptide measurement for CHF, creatinine measurement and urinalysis for renal disease, hepatic enzyme and albumin measurement for hepatic disease, D-dimer enzyme-linked immunosorbent assay to rule out DVT in low-risk patients. Venous ultrasonography, imaging modality of choice for suspected DVT. Lymphoscintigraphy, to assess lymph flow, which cannot be detected with ultrasonography. Magnetic resonance imaging, for unilateral lower extremity edema without proximal thrombosis on duplex ultrasonography. Magnetic resonance angiography with venography of the lower extremity and pelvis for intrinsic or extrinsic pelvic or thigh DVT. Echocardiography, to evaluate pulmonary arterial pressures, recommended for patients with obstructive sleep apnea and edema. Hypoxia and cyanosis. Hypoxia. Hypoxia is defined as a decrease in O2 delivery to or utilization by the tissues. Hypoxia may be classified as either generalized, affecting the whole body, or local, affecting a region of the body. Causes. Ischemia is decreased blood flow through an organ. Arises with decreased arterial perfusion, e.g. atherosclerosis, decreased venous drainage, e.g. Budd-Chiari syndrome, shock, generalized hypotension resulting in poor tissue perfusion. Hypoxemia, inadequate amount of oxygen traveling in the blood, is a low partial pressure of oxygen in the blood, PaO2. Headache, differential diagnosis. Primary headache syndromes, migraines, cluster headache, tension headache. Secondary causes of headache, vomit, vascular, subarachnoid hemorrhage, subdural hematoma, epidural hematoma, intraparenchymal hemorrhage, temporal arteritis, other causes, malignant HTN hypertension, pseudotumor cerebri, post-lumbar puncture, pheochromocytoma, medication drug-related, nitrates, alcohol withdrawal, chronic analgesic use abuse, infection, meningitis, encephalitis, cerebral abscess, sinusitis, herpes zoster, fever, tumor. Dysphagia causes lower esophageal ring, peptic stricture, esophageal carcinoma, diffuse esophageal spasm, scleroderma, achalasia, muscular and neurologic disorders, stroke, Parkinson's disease, ALS, amyotrophic lateral sclerosis, NG, possibly referring to nasogastric intubation complications, muscular dystrophy, Zenker's diverticulum. Nausea and vomiting causes pregnancy, normal pregnancy, hyperemesis gravidarum, metabolic, diabetic ketoacidosis, Addison disease, uremia, electrolyte disturbance, hypercalcemia, hypokalemia, hyperthyroidism, GI, gastrointestinal, gastroenteritis, viral, food poisoning, PUD, peptic ulcer disease, GERD, gastroesophageal reflux disease, gastroparesis, diabetics, gastric outlet obstruction, intestinal obstruction, SBO, small bowel obstruction, pseudo-obstruction, ileus, peritonitis, acute visceral conditions, pancreatitis, appendicitis, pyelonephritis, cholecystitis, cholangitis, neurologic, increased intracranial pressure, vestibular disturbance, vertigo, migraine, acute MI, myocardial infarction, drugs, chemotherapy, digoxin, ASA NSAIDs, narcotics, antibiotics, excessive alcohol intake, psychiatric, eating disorder, bulimia nervosa, anorexia nervosa, anxiety, miscellaneous, motion sickness, systemic illness, radiation therapy postoperatively. Diarrhea. Causes. Acute diarrhea, infection, viruses most common, viral gastroenteritis, bacteria, parasites. Medications, antibiotics most common cause, laxatives, prokinetic agents, cisapride, antacids, digitalis, colchicine, alcohol, magnesium-containing antacids, chemotherapeutic agents, malabsorption, e.g. lactose intolerance, ischemic bowel in elderly patients with history of pad and bloody diarrhea, along with abdominal pain. Intestinal tumors, very rare. Chronic diarrhea, IBS, irritable bowel syndrome, inflammatory bowel disease, IBD, medications, infection, colon cancer, diverticulitis, malabsorption syndromes, pancreatic insufficiency, celiac disease, short bowel syndrome, ischemic bowel bacterial overgrowth, post-surgical, e.g. gastrectomy, vagotomy, endocrine causes, hyperthyroidism, Addison disease, diabetes, gastronoma, VIP homa, fecal impaction, because only liquid stool can pass around the impaction, laxative abuse, factitious diarrhea, immunocompromised patients with acute infectious diarrhea. Constipation, causes, diet, lack of fiber, medications, anticholinergic drugs, antipsychotics, antidepressants, narcotic analgesics, iron, calcium channel blockers, aluminum or calcium containing antacids, laxative abuse and dependence, IBS, irritable bowel syndrome, obstruction, colorectal cancer, CRC, always keep this in mind, anal stricture, hemorrhoids, anal fissure, ileus, pseudo-obstruction, anorectal problems, hemorrhoids, fissures, endocrine metabolic causes, hypothyroidism, hypercalcemia, hypokalemia, uremia, dehydration, neuromuscular disorders, Parkinson disease, multiple sclerosis, CNS lesions, scleroderma, DM, diabetes mellitus with autonomic neuropathy, congenital disorders, Hirschsprung disease. Gastrointestinal management. If patient is hemodynamically unstable, resuscitation is always top priority. Remember the ABCs. Once the patient is stabilized, obtain a diagnosis. Supplemental oxygen. Place 2 large bore IV lines. Give IV fluids or blood if patient is volume depleted. Draw blood for hemoglobin and hematocrit, PT, PTT, and platelet count. Monitor hemoglobin every 4 to 8 hours until the patient is hemoglobin stable for at least 24 hours. Type and cross-match adequate blood, BC. Transfuse as the clinical condition demands, e.g., shock, patients with cardiopulmonary disease. Treatment depends on the cause source of the bleed. Upper GI bleeding, EGD with coagulation of the bleeding vessel. If bleeding continues, repeat endoscopic therapy or proceed with surgical intervention, ligation of bleeding vessel. Lower GI bleeding, colonoscopy, polyp excision, injection, laser, cautery, arteriographic vasoconstrictor infusion, surgical resection of involved area, last resort. Indications for surgery: hemodynamically unstable patients who have not responded to IV fluid, transfusion, endoscopic intervention, or correction of coagulopathies. Severe initial bleed or recurrence of bleed after endoscopic treatment. Continued bleeding for more than 24 hours. Visible vessel at base of ulcer, 30 to 50% chance of rebleed. Ongoing transfusion requirement, 5 units within first 4 to 6 hours. Jaundice, causes and diagnostics. Causes: conjugated hyperbilirubinemia, urine positive for bilirubin, decreased intrahepatic excretion of bilirubin, hepatocellular disease, viral or alcoholic hepatitis, cirrhosis, inherited disorders, Dubin-Johnson syndrome, Rotor syndrome, drug-induced oral contraceptives, PBC, primary biliary cirrhosis, primary sclerosing cholangitis, PSC, extrahepatic biliary obstruction, gallstones, carcinoma of head of pancreas, cholangiocarcinoma, periampullary tumors, extrahepatic biliary atresia, unconjugated hyperbilirubinemia, urine negative for bilirubin, excess production of bilirubin, hemolytic anemias, reduced hepatic uptake of bilirubin or impaired conjugation. Gilbert syndrome, drugs, e.g., sulfonamides, penicillin, rifampin, radiocontrast agents. Crigler-Nadger syndrome, physiologic jaundice of the newborn, immaturity of conjugating system, diffuse liver disease, hepatitis, cirrhosis. Abdominal swelling and ascites, accumulation of fluid in the peritoneal cavity, due to portal HTN, increased hydrostatic pressure, and hypoalbuminemia, reduced oncotic pressure. Ascites, most common complication of cirrhosis. Clinical features: abdominal distension, shifting dullness, fluid wave. Abdominal ultrasound can detect as little as 30 milliliters of fluid. Diagnostic paracentesis determines whether ascites is due to portal HTN or another process. Indications: new onset ascites, worsening ascites, suspected spontaneous bacterial peritonitis, SBP. Examinations include cell count, ascites albumin, gram stain and culture to rule out infection, e.g. SBP. Measure the serum ascites albumin gradient, SAG. If 1.1 granular, portal HTN is very likely. If 1.1 granular, portal HTN is unlikely, and other causes must be considered. Treatment: bed rest, a low-sodium diet and diuretics, furosemide and spironolactone. Perform therapeutic paracentesis if tense ascites, shortness of breath, or early satiety is present. Peritoneovenous shunt or tips to reduce portal HTN. Differential diagnosis of ascites: cirrhosis, portal HTN, CHF, congestive heart failure, chronic renal disease, massive fluid overload, tuberculous peritonitis, malignancy. Hypoalbuminemia, peripheral vasodilation secondary to endotoxin-induced release of nitrous oxide, which leads to increased renin secretion and thus secondary hyperaldosteronism. Impaired liver inactivation of aldosterone. Hepatomegaly, common causes: infective, glandular fever, infectious mononucleosis, hepatitis A, B, or C, liver abscess, pyogenic abscess, malaria, amoeba infections, hydatid cyst, leptospirosis, actinomycosis. Neoplastic, metastatic tumors, hepatocellular carcinoma, myeloma, leukemia, lymphoma. Biliary, primary biliary cirrhosis, primary sclerosing cholangitis. Metabolic, hemochromatosis, cholesterol ester storage disease, porphyria, Wilson's disease, Niemann-Pick disease, non-alcoholic fatty liver disease, glycogen storage disease, GSD, drugs including alcohol, alcohol abuse, drug-induced hepatitis, congenital hemolytic anemia, polycystic liver disease, sickle cell disease, hereditary fructose intolerance. Diagnosis of abdominal pain. Differential diagnosis: right upper quadrant, biliary, cholecystitis, cholelithiasis, cholangitis, colonic, colitis, diverticulitis, hepatic, abscess, hepatitis, mass, pulmonary, pneumonia, embolus, renal, nephrolithiasis, pyelonephritis, epigastric, biliary, cholecystitis, cholelithiasis, cholangitis, cardiac, myocardial infarction, pericarditis, gastric, esophagitis, gastritis, peptic ulcer, pancreatic, mass, pancreatitis, vascular, aortic dissection, mesenteric ischemia, left upper quadrant, cardiac, angina, myocardial infarction, pericarditis, gastric, esophagitis, gastritis, peptic ulcer, mass, pancreatitis, renal, nephrolithiasis, pyelonephritis, vascular aortic dissection, mesenteric ischemia, periumbilical, colonic, early appendicitis, gastric, esophagitis, gastritis, peptic ulcer, small bowel mass or obstruction, vascular, aortic dissection, mesenteric ischemia, right lower quadrant, colonic appendicitis, colitis, diverticulitis, IBD, IBS, gynecologic, ectopic pregnancy, fibroids, ovarian mass, torsion, PID, renal, nephrolithiasis, pyelonephritis, left lower quadrant, colonic, colitis, diverticulitis, IBD, IBS, gynecologic, ectopic pregnancy, fibroids, ovarian mass, torsion, physical examination. Patients with peritonitis tend to lie very still, whereas those with renal colic seem unable to stay still. Fever suggests infection. Tachycardia and orthostatic hypotension suggest hypovolemia. Carnet's sign: increased pain when a supine patient tenses the abdominal wall by lifting the head and shoulders off the examination table in patients with abdominal wall pain. Murphy's sign in patients with cholecystitis. Psoas sign in patients with appendicitis. A rectal examination may reveal fecal impaction, a palpable mass, or occult blood in the stool. Laboratory tests. A complete blood count is appropriate if infection or blood loss is suspected. In patients with epigastric pain, simultaneous amylase and lipase measurements. Liver chemistries are important in patients with right upper quadrant pain. A urinalysis should be obtained in patients with hematuria, dysuria, or flank pain. A urine pregnancy test should be performed in women of childbearing age who have abdominal pain to narrow the differential diagnosis and to determine whether certain imaging studies are appropriate. Imaging studies. Lymph node enlargement, differential diagnosis. Reactive, acute infection, e.g. bacterial or viral, or chronic infections, tuberculous lymphadenitis, cat scratch disease. Tumoral, primary, Hodgkin lymphoma and non-Hodgkin lymphoma give lymphadenopathy in all or a few lymph nodes. Secondary, metastasis, Virchow's node, neuroblastoma, and chronic lymphocytic leukemia. Autoimmune, systemic lupus erythematosus and rheumatoid arthritis may have a generalized lymphadenopathy. Immunocompromised, AIDS, bites from certain venomous snakes, such as the pit viper. Unknown, Kikuchi disease, progressive transformation of germinal centers, sarcoidosis, hyaline vascular variant of Castleman's disease, Rosai-Dorfman disease, Kawasaki disease, Kimura disease. Benign, reactive lymphadenopathy,
Sure, here is the information you provided, organized and with key terms highlighted. Bone marrow biopsy indications. Diagnosis, staging, and therapeutic monitoring for lymphoproliferative disorders such as chronic lymphocytic leukemia, CLL, Hodgkin and non-Hodgkin lymphoma, hairy cell leukemia, myeloproliferative disorders, myelodysplastic syndrome, and multiple myeloma. Evaluation of cytopenia, thrombocytosis, leukocytosis, anemia, and iron status. To rule out infiltrative infectious diseases such as fungal infections, tuberculosis, and other granulomatoses. Investigation for fever of unknown origin FUO, specifically in those patients with AIDS. Diagnosis of storage diseases, e.g. Niemann-Pick disease and Gaucher disease. Assessment for metastatic carcinoma and granulomatous diseases, e.g. sarcoidosis. May reveal toxic effects of certain offending medications or substances, e.g. alcohol, or nutritional deficiencies, e.g. deficiencies of copper/zinc or vitamin B12/folate. Patients with idiopathic thrombocytopenic purpura (ITP), incidental elevated serum paraprotein levels, iron deficiency anemia, polycythemia vera, essential thrombocytosis, or infectious mononucleosis. Sure, here is the information you provided, organized and with key terms highlighted. Polyuria, differential diagnosis. General. Polydipsia. Psychogenic polydipsia. Diuretic drugs, osmotic diuresis. Urinary system. Interstitial cystitis. Urinary tract infection. Renal tubular acidosis. Fanconi syndrome. Nephronophthisis genetic. Hormonal. Hypokalemia. Diabetes mellitus. Corticosteroid use. Pheochromocytoma, hyperparathyroidism, diabetes insipidus, hypercalcemia, hyperthyroidism, hypopituitarism, Conn's disease, hyperglycemia, circulation, congestive heart failure, cardiorespiratory disease, postural orthostatic tachycardia syndrome (POTS), neurologic, cerebral salt wasting syndrome, neurologic damage, migraine, other, high doses of riboflavin vitamin B2, high doses of vitamin D, altitude diuresis, side effect of lithium, hemochromatosis, acrotoxicosis. Sure, here is the information you provided, organized and with key terms highlighted. Mechanisms leading to the development of venous thromboembolism. Stasis. Phenomena of interrupted blood flow. These include venous stasis, long surgical operations, prolonged immobility whilst on a long plane or car ride bedbound during hospitalization, and varicose veins. Endothelial injury. Vessel piercings and damages arising from shear stress or hypertension. Hypercoagulability. Alterations in the constitution of blood. Risk factors such as hyperviscosity, coagulation factor V Leiden mutation, coagulation factor 2G2021A mutation, deficiency of antithrombin 3, protein C or S deficiency, nephrotic syndrome, changes after severe trauma or burn, cancer, late pregnancy and delivery, race, advanced age, cigarette smoking, hormonal contraceptives, and obesity. Sure, here is the information you provided, organized and with key terms highlighted. Cough, differential diagnosis. Upper respiratory infections, URIs. Pulmonary disease, pneumonia, chronic obstructive pulmonary disease, COPD, pulmonary fibrosis, lung cancer, asthma, lung abscess, tuberculosis. CHF with pulmonary edema. Smoking. Postnasal drip may be caused by URIs, viral infections, rhinitis, allergic or non-allergic, chronic sinusitis, or airborne irritants. Gastroesophageal reflux disease, GERD. Especially if nocturnal cough, when lying flat, reflux worsens due to position and decreased lower esophageal sphincter acetone. Asthma. ACE inhibitors may cause a dry cough due to bradykinin production. Sure, here is the information you provided, organized and with key terms highlighted. Major causes of hemoptysis. Bronchitis, 50% of cases. Lung cancer, bronchogenic carcinoma. Tuberculosis, TB. Bronchiectasis. Pneumonia. Idiopathic. Goodpasture syndrome. Pulmonary embolism, PE with pulmonary infarction. Aspergilloma within cavities. Mitral stenosis, elevated pulmonary venous pressure. Hemophilia. Sure, here is the information you provided, organized and with key terms highlighted. Systemic inflammatory response syndrome, SIRS definition and causes. Definition: SIRS is an inflammatory state affecting the whole body. It is the body's response to an infectious or non-infectious insult. SIRS is frequently complicated by failure of one or more organs or organ systems. Complications of SIRS include acute kidney injury, shock, multiple organ dysfunction syndrome. Causes of SIRS include bacterial infections, severe malaria, trauma, burns, pancreatitis, ischemia, hemorrhage, complications of surgery, adrenal insufficiency, pulmonary embolism, complicated aortic aneurysm, cardiac tamponade, anaphylaxis, drug overdose. Sure, here is the information you provided, organized and with key terms highlighted. Dehydration, clinical examination, and laboratory abnormalities. A patient presenting symptoms such as disorientation, low blood pressure, rapid heartbeat, fever, lack of sweat, and inelastic skin will usually be considered dehydrated. Blood tests are often employed to test kidney function and to check sodium, potassium, and other electrolyte levels. A urine analysis will provide very useful information to help diagnose dehydration. In a dehydrated person, urine will be darker in color and more concentrated, containing a certain level of compounds called ketones. Sure, here is the information you provided, organized and with key terms highlighted. Signs and symptoms of chronic heart failure. Symptoms of left-sided heart failure. Dyspnea secondary to pulmonary congestion/edema. Orthopnea, difficulty breathing in the recumbent position, relieved by elevation of the head with pillows. Paroxysmal nocturnal dyspnea, PND. Nocturnal cough, non-productive. Confusion and memory impairment occur in advanced CHF as a result of inadequate brain perfusion. Diaphoresis and cool extremities at rest occur in desperately ill patients, NYHA Class 4. Signs of left-sided heart failure. Displaced PMI, usually to the left due to cardiomegaly. Pathologic S3 ventricular gallop. Rapid filling phase into a non-compliant left ventricular chamber. Heard best at apex. The sequence in the cardiac cycle for S3 follows S2 Kenneck Y, S4 gallop. Sound of atrial systole as blood is ejected into a non-compliant or stiff left ventricular chamber. Heard best at left sternal border. The sequence in the cardiac cycle for S4 precedes S1 10SC. Crackles/rals at lung bases. Caused by fluid spilling into alveoli indicates pulmonary edema. Dullness to percussion and decreased tactile fremitus of lower lung fields. Caused by pleural effusion. Increased intensity of pulmonic component of second heart sound. Indicates pulmonary HTN heard over left upper sternal border. Symptoms/signs of right-sided heart failure. Peripheral pitting edema. Lacks specificity. In the elderly, it is more likely to be secondary to venous insufficiency. Nocturia due to increased venous return with elevation of legs. Jugular venous distension, JVD. Hepatomegaly/hepatojugular reflux. Ascites. Right ventricular heave. Sure, here is the information you provided, organized and with key terms highlighted. Pharmacotherapy of chronic heart failure. Diuretics. Providing symptomatic relief. Recommended for patients with systolic failure and volume overload. Goal is relief of signs and symptoms of volume overload, dyspnea, peripheral edema. Loop diuretics, furosemide. Thiazide diuretics, hydrochlorothiazide. Spironolactone aldosterone antagonist. Monitor serum potassium and renal function. Effective only for more advanced stages of CHF, classes 3 and 4. Eplerenone is an alternative to spironolactone, does not cause gynecomastia. ACE inhibitors. Cause venous and arterial dilation, decreasing preload and afterload. Indicated for left ventricular systolic dysfunction, LVEF less than 40%. All patients with systolic dysfunction should be on an ACE inhibitor even if they are asymptomatic. Always start at a low dose to prevent hypotension. Monitor BP, potassium, BUN, and creatinine. Angiotensin II receptor blockers, ARBs. Used in patients unable to take ACE inhibitors due to side effect of cough, but should not replace ACE inhibitors if patient tolerates an ACE inhibitor. Beta blockers. Slow progression of heart failure by slowing down tissue remodeling. The decrease in heart rate leads to decreased oxygen consumption. Also have antiarrhythmic and anti-ischemic effect. Not all beta blockers are equal. There is evidence only for metoprolol, bisoprolol, and carvedilol. Digitalis. Positive inotropic agent. Useful in patients with EF less than 40%, severe CHF, or severe AFib. Used to control dyspnea. For patients with EF less than 40% who continue to have symptoms despite optimal therapy. Serum digoxin levels should be checked periodically. Hydralazine and isosorbide dinitrates. Can be used in patients who cannot tolerate ACE inhibitors. Require inconvenient dosing schedules. The following medications are contraindicated in patients with CHF. Metformin may cause potentially lethal lactic acidosis. Thiazolidinediones causes fluid retention. NSAIDs may increase risk of CHF exacerbation. Some antiarrhythmic agents that have negative inotropic effects. Diastolic dysfunction. Few therapeutic options available. Patients are treated symptomatically. Beta blockers. Diuretics are used for symptom control, volume overload. Digoxin and spironolactone should not be used. ACE inhibitors and ARBs. Benefit is not clear for diastolic dysfunction. Sure, here is the information you provided, organized and with key terms highlighted. Treatment of chronic heart failure beyond drugs. General lifestyle modification. Sodium restriction less than 4 g/day. Fluid restriction 1.5 to 2.0 L daily. Weight loss. Smoking cessation. Restrict alcohol use. Exercise program. All patients should monitor weight daily to detect fluid accumulation. Annual influenza vaccine and pneumococcal vaccine recommended. An ICD lowers mortality by helping prevent sudden cardiac death, which is the most common cause of death in CHF. It is indicated for patients at least 40 days post-MI, EF less than 35%, and class 2 or 3 symptoms despite optimal medical treatment. Cardiac resynchronization therapy, CRT. This is a biventricular pacemaker. Indicated for patients at least 40 days post-MI, EF less than 35%, and class 2 or 3 symptoms despite optimal medical treatment plus prolonged QRS duration greater than 120 millisecond. Cardiac transplantation is the last alternative if the above do not control symptoms.
Certainly. Here's a more focused summary on the treatment of pulmonary edema, especially emphasizing pharmacological interventions and other medical strategies relevant to internal medicine. General management of pulmonary edema. 1. Airway management. If the patient has decreased consciousness, tracheal intubation and mechanical ventilation might be necessary to maintain airway patency and prevent hypoxia. 2. Oxygen supplementation. Administer supplemental oxygen if there are signs of hypoxia. If this does not suffice, mechanical ventilation may be required to prevent further complications. 3. Identify and treat the underlying cause. For pulmonary edema due to infection, administer appropriate antibiotics targeting the causative pathogen. Specific treatments for cardiogenic pulmonary edema. 1. Positioning. Keeping the patient upright can help alleviate symptoms. 2. Pharmacologic interventions. Diuretics. Administer a loop diuretic such as furosemide to reduce fluid overload. Morphine, used to reduce respiratory distress and anxiety, also has mild vasodilatory effects. Vasodilators. Administer specific vasodilators like glycerol trinitrate or isosorbide dinitrate ISDN if blood pressure allows to reduce cardiac preload and afterload. 3. Ventilatory support. Non-invasive ventilation such as continuous positive airway pressure, CPAP, or bilevel positive airway pressure, BiPAP, can reduce the need for intubation in severe cases by improving oxygenation and reducing the work of breathing. 4. Management of cardiogenic shock. In cases where cardiogenic pulmonary edema coexists with cardiogenic shock, treatments may include inotropic agents, such as dobutamine or milrinone, to improve myocardial contractility. Mechanical circulatory support, such as the intra-aortic balloon pump, IABP, as a temporary measure while addressing the root cause. Priority considerations. It's crucial to stabilize the patient with supportive measures while simultaneously identifying and treating the underlying cause of the pulmonary edema. This dual approach helps in managing symptoms and preventing future episodes. This focused overview covers the essential treatments and drugs you should be familiar with for managing pulmonary edema, especially from a cardiogenic origin, which is highly relevant for the internal medicine exam. For your internal medicine exam, it's crucial to have a clear understanding of the risk factors for coronary artery disease, CAD, and their management. Here's a summary with a focus on specific interventions and drug names. Major modifiable risk factors. 1. Elevated cholesterol levels. Statins, e.g. atorvastatin, simvastatin, are primary for lowering LDL cholesterol. Niacin and fibrates, e.g. fenofibrate, can be used to modify other lipid profiles when necessary. 2. Tobacco. Cessation is crucial. Nicotine replacement therapy, patches, gum, and medications like varenicline and bupropion can aid in quitting. 3. Hypertension, HTN. Antihypertensive drugs such as ACE inhibitors, e.g. lisinopril, ARBs, e.g. losartan, beta blockers, e.g. metoprolol, calcium channel blockers, e.g. amlodipine, and diuretics, e.g. hydrochlorothiazide. 4. Physical inactivity and exercise. Increasing physical activity as a preventive measure. No specific drugs, but lifestyle modifications are recommended. 5. Obesity. Weight management through diet and exercise. In some cases, medications like orlistat or GLP-1 agonists, e.g. liraglutide, might be prescribed. 6. Diabetes mellitus. Managing blood sugar with medications like metformin, SGLT2 inhibitors, e.g. empagliflozin, or insulin, depending on the type and severity of diabetes. Major unmodifiable risk factors. 1. Age. Risk increases with age to 65. Focus on managing modifiable factors to mitigate risk. 2. Sex. Men have a higher risk of ischemic heart disease, IHD, than women premenopause. 3. Heredity and family history. A family history of premature disease significantly raises risk. No specific treatment, but increased surveillance and aggressive management of modifiable risks are recommended. Minor contributing factors. 1. Sex hormones. Postmenopausal women may have an increased risk due to decreased levels of natural estrogen. Hormone replacement therapy, HRT, has been used in the past, but its role is controversial due to associated risks. 2. Stress. Management includes lifestyle interventions and potentially anxiolytic medications or antidepressants in cases of related mental health issues. Key points. Focus on aggressively managing modifiable risks with both lifestyle changes and pharmacotherapy. Regular screening and preventive strategies are crucial for individuals with unmodifiable risk factors. Treatment plans should be personalized, especially in individuals with multiple risk factors or a family history of CAD. Understanding and managing these risk factors through both lifestyle modification and medication can significantly reduce the incidence and severity of coronary artery disease, a critical aspect of internal medicine. For your internal medicine exam, it's important to grasp the elements of primary prevention of cardiovascular diseases, CVD. Here's a detailed summary focusing on preventive strategies, including specific drug names and lifestyle modifications. Primary prevention of cardiovascular diseases. Primary prevention aims to prevent the initial occurrence of cardiovascular diseases in individuals who have risk factors but have not yet developed clinically manifest CVD. 1. Healthy diet. Promote a diet rich in fruits, vegetables, whole grains, lean proteins, and healthy fats. Reduce intake of saturated fats, trans fats, and processed foods. 2. Weight loss. Encourage a calorie-controlled diet and physical activity to achieve and maintain a healthy body weight. 3. Physical activity. Recommend at least 150 minutes of moderate intensity aerobic exercise or 75 minutes of vigorous intensity aerobic exercise per week. 4. Control of diabetes. Monitor and manage blood glucose levels through lifestyle interventions and medications such as metformin and newer agents like SGLT2 inhibitors, e.g. empagliflozin, and GLP-1 receptor agonists, e.g. liraglutide. 5. Statin treatment. Use statins, e.g. atorvastatin, simvastatin, to manage cholesterol levels, particularly in individuals with high LDL cholesterol or those calculated at high risk for cardiovascular events using risk scores. 6. Control of hypertension. Employ antihypertensive medications such as ACE inhibitors, e.g. lisinopril, ARBs, e.g. losartan, beta blockers, e.g. metoprolol, calcium channel blockers, e.g. amlodipine, and diuretics, e.g. hydrochlorothiazide. 7. Tobacco smoke cessation. Advise quitting smoking and offer support through nicotine replacement therapy, patches, gum, and medications like varenicline or bupropion to aid cessation. 8. Low-dose aspirin. Consider for adults aged 40 to 70 years at higher risk for atherosclerotic cardiovascular disease, CVD, who are not at increased risk for bleeding. Recent guidelines recommend using low-dose aspirin selectively, considering individual cardiovascular risk and bleeding risk. Key considerations. Personalized preventive strategies based on individual risk profiles, taking into account factors like age, sex, family history, and existing health conditions. Regular screening and monitoring for hypertension, hyperlipidemia, and diabetes are crucial in adjusting preventive measures. Educate patients about the importance of lifestyle modifications in conjunction with pharmacotherapy to optimize cardiovascular health. Understanding these preventive strategies and when to apply them, including specific medications, will be crucial for managing patients at risk of CVD and for your preparation for the internal medicine exam. For your internal medicine exam, understanding the pathogenesis and clinical features of ischemic heart disease, IHD, along with the relevant drugs used in management is crucial. Here's a detailed summary. Pathogenesis ischemic heart disease, IHD, along with the relevant drugs used in management is crucial. Here's a detailed summary. Pathogenesis of ischemic heart disease. One general mechanism. Imbalance between coronary oxygen demand and supply, typically due to atherosclerotic plaque which narrows coronary arteries. Acute coronary syndrome, ACS, occurs when a plaque ruptures, leading to thrombus formation and sudden artery occlusion. Other causes like coronary artery embolism, spasm, arteritis, or dissection can also precipitate IHD. Types of angina pectoris and myocardial infarction. Stable angina pectoris, pathogenesis. Fixed atherosclerotic lesions narrow coronary arteries, causing ischemia during increased oxygen demand situations like physical exertion. Clinical features. Chest pain described as heaviness or squeezing, typically lasting less than 15 minutes and relieved by rest or nitroglycerin. Unstable angina pectoris, pathogenesis, increased stenosis due to plaque rupture, thrombosis, or hemorrhage, reducing resting coronary flow and potentially leading to vessel occlusion. Clinical features. Worsening pattern or new onset of severe angina, including at rest. Variant, Prinzmetal, pathogenesis, caused by transient coronary vasospasm with or without underlying atherosclerosis. Clinical features. Angina occurring at rest, often at night, and can be associated with ventricular dysrhythmias. Myocardial infarction. Pathogenesis. Prolonged coronary blockage after thrombotic occlusion causes myocardial necrosis. Clinical features. Severe, crushing chest pain, not relieved by nitroglycerin, possibly radiating to the neck, jaw, or arms, accompanied by symptoms like dyspnea, diaphoresis, nausea, and a sense of doom. Pharmacological management. 1. Nitrates, e.g. nitroglycerin, used to relieve angina by dilating blood vessels and reducing myocardial oxygen demand. 2. Antiplatelet agents, aspirin, often used in low doses to prevent platelet aggregation. Clopidogrel, used especially in patients intolerant to aspirin or in combination therapy for ACS. 3. Beta blockers, e.g. metoprolol, atenolol, reduce myocardial oxygen demand by slowing the heart rate and reducing contractility. 4. Calcium channel blockers, e.g. amlodipine, diltiazem, used particularly for coronary vasospasm in Prinzmetal angina and to reduce cardiac workload in other forms of angina. 5. ACE inhibitors, e.g. lisinopril, benefit patients with systolic dysfunction or those who have had an MI by reducing cardiac remodeling and mortality. 6. Statins, e.g. atorvastatin, simvastatin, essential for managing cholesterol levels and stabilizing atherosclerotic plaques. 7. Thrombolytics, e.g. alteplase, used in acute MI to dissolve thrombi and restore coronary flow. Summary. Understanding the mechanisms leading to ischemic heart disease, recognizing clinical presentations, and knowing the pharmacological treatments are fundamental. Management focuses on restoring balance between oxygen supply and demand, preventing thrombosis, and relieving symptoms. This knowledge is essential for effectively treating patients and excelling in your internal medicine exam. For your internal medicine exam, understanding the secondary prevention of coronary artery disease, (CDD), is crucial, particularly focusing on the pharmacologic treatments and interventions for patients with established cardiovascular disease. Here's a detailed summary with specifics on medications and therapeutic strategies. Secondary prevention of coronary artery disease. Secondary prevention aims to prevent recurrent cardiovascular events in individuals with established coronary heart disease, CHD, cerebrovascular disease, CEVD, or peripheral vascular disease. 1. Smoking cessation. Crucial for reducing further cardiovascular risk. Assistance might include pharmacological aids such as nicotine replacement therapy, bupropion, or varenicline. 2. Dietary changes. Adopting a heart-healthy diet, low in saturated fats and high in fiber, can help manage lipid levels and overall cardiovascular risk. 3. Physical activity. Encourage regular moderate exercise, aiming for at least 150 minutes of moderate intensity aerobic activity per week. 4. Weight control. Important for reducing the burden on the heart and improving overall cardiovascular health. 5. Antihypertensive drugs include ACE inhibitors, e.g. lisinopril, ARBs, e.g. losartan, beta blockers, e.g. metoprolol, calcium channel blockers, e.g. amlodipine, and diuretics, e.g. hydrochlorothiazide. 6. Lipid-lowering drugs, statins, e.g. atorvastatin, simvastatin, are the mainstay for reducing LDL cholesterol and stabilizing plaques. Other agents include PCSK9 inhibitors, e.g. evolocumab, fibrates, and niacin. 7. Hypoglycemic drugs. In diabetic patients, maintaining blood glucose control is vital, often using metformin SGLT2 inhibitors, e.g. empagliflozin, or GLP-1 receptor agonists, e.g. liraglutide. 8. Antiplatelet drugs, aspirin and P2Y12 inhibitors, e.g. clopidogrel, are commonly used to prevent thrombosis in arterial circulation. 9. Post-myocardial infarction management. ACE inhibitors are recommended to improve survival, reduce myocardial remodeling, and prevent heart failure. Beta blockers are essential for reducing myocardial oxygen demand and preventing arrhythmias. 10. Anticoagulant treatment. Used primarily in patients with atrial fibrillation or left ventricular dysfunction, drugs like warfarin, dabigatran, apixaban, or rivaroxaban can be employed to prevent thromboembolic events. 11. Coronary revascularization. Procedures like percutaneous coronary intervention, PCI, or coronary artery bypass grafting, CABG, are used to restore blood flow to ischemic heart regions. 12. Carotid endarterectomy, indicated for patients with significant carotid artery stenosis who have had a previous TIA or non-disabling stroke to reduce the risk of future stroke. Key points. Secondary prevention in CAD involves a comprehensive approach that includes lifestyle modifications, pharmacotherapy, and potentially surgical or interventional procedures to reduce the risk of recurrent cardiovascular events. Personalization of therapy based on individual risk factors, comorbidities, and previous cardiovascular events is essential for optimal care. This multifaceted approach is crucial for managing patients with established cardiovascular diseases effectively, and knowing these details will be valuable for your exam preparation. For your internal medicine exam, it's important to have a solid understanding of the various invasive cardiology treatments, focusing on their mechanisms and when they are typically employed. Here's a concise summary that might help. Invasive treatments in cardiology. 1. Angioplasty. Percutaneous transluminal angioplasty, PTA. Purpose: used to widen narrowed or obstructed arteries or veins, primarily for arterial atherosclerosis. Procedure: a deflated balloon on a catheter is inserted over a guide wire into the narrowed vessel, inflated to widen the vessel, and often combined with stent placement to keep the artery open. 2. Valvuloplasty. Purpose: dilation of narrowed cardiac valves, commonly mitral, aortic, or pulmonary valves. Procedure: similar approach to angioplasty, but applied to cardiac valves to improve valve function and blood flow. 3. Congenital heart defect correction. Purpose: corrects defects like atrial septal defects, ventricular septal defects, and closure of a patent ductus arteriosus. Procedure: utilizes percutaneous techniques to repair structural heart defects without open surgery. 4. Percutaneous valve replacement. Purpose: replacement of heart valves via percutaneous methods, an alternative to open heart surgery. Specifics: commonly performed on the aortic valve, transcatheter aortic valve implantation TAVI, and recently applicable to pulmonary and mitral valves. 5. Percutaneous valve repair. Purpose: specifically performed on the mitral valve to repair without requiring open heart surgery. 6. Coronary thrombectomy. Purpose: removal of a thrombus blood clot from the coronary arteries, typically during acute coronary syndromes to restore blood flow. Or 7. Coronary artery bypass graft, CAG. Surgical procedure to restore normal blood flow to an obstructed coronary artery. Procedure: involves grafting a vessel like the great saphenous vein or the left internal thoracic artery, LIDA, also known as lima, to bypass the blocked artery. Indications: used to relieve symptoms of severe angina, prevent or manage left ventricular dysfunction, and reduce the risk of death from coronary artery disease. Does not prevent myocardial infarction. Summary points: these procedures are crucial for treating structural and coronary artery diseases, offering alternatives to more invasive surgeries and addressing conditions that pharmacotherapy alone cannot manage. Understanding when and how each procedure is indicated, as well as their benefits and limitations, is essential for managing patients effectively in clinical practice. Focus on how these procedures complement drug therapies and other non-invasive strategies in comprehensive cardiovascular care. This integrated knowledge is vital for your internal medicine exam. For your internal medicine exam, it's crucial to recognize the clinical presentation of an acute myocardial infarction, AMI, as well as understanding the immediate pharmacological interventions. Here's a focused summary. Clinical presentation of acute myocardial infarction. 1. Chest pain. Characterized as intense substernal pressure or a crushing sensation, often described as feeling like an elephant standing on my chest. Pain may radiate to the neck, jaw, arms, or back, commonly on the left side. Unlike angina, pain from an AMI typically does not respond to nitroglycerin. 2. Atypical presentations. Painless infarcts or atypical symptoms are more likely in postoperative patients, the elderly, diabetic patients, and women. These might include breathlessness, fatigue, or a general unwell feeling without the classic chest pain. 3. Additional symptoms. Dyspnea, shortness of breath, diaphoresis, excessive sweating, weakness, fatigue, general feeling of being unwell, nausea and vomiting, often accompanying the pain, sense of impending doom, anxiety or feeling that something bad is going to happen, syncope, fainting spells due to decreased blood flow to the brain, Sudden cardiac death, often due to ventricular fibrillation, VFib, which requires immediate intervention. Initial pharmacological management: 1. Antiplatelet agents, aspirin, chewable 325 milligrams initially to inhibit platelet aggregation. P2Y12 inhibitors, such as clopidogrel, ticagrelor, or prasugrel, may be added depending on the situation and planned management strategy, e.g., PCI. 2. Anticoagulants, heparin, unfractionated or low molecular weight heparin to prevent further thrombosis. Bivalirudin is an alternative, particularly during percutaneous coronary intervention, PCI. 3. Pain management and vasodilation. Morphine is used to relieve pain and anxiety, which can also have a mild vasodilatory effect to reduce cardiac workload. 4. Beta blockers. Drugs like metoprolol are used early to reduce myocardial oxygen demand and limit the size of the infarct. 5. ACE inhibitors, initiated within the first 24 hours in patients without hypotension to improve survival outcomes, reduce myocardial remodeling, and prevent heart failure. 6. Statins. High-intensity statins like atorvastatin, 80 milligrams, are recommended to stabilize plaques and reduce cholesterol levels rapidly. 7. Reperfusion therapy. Thrombolytics, e.g. alteplase, retaplase, tenecteplase, if PCI is not available within 120 minutes from the first medical contact in STEMI patients. Summary. Understanding the typical and atypical presentations of AMI and initiating appropriate pharmacological treatment rapidly are key components in reducing mortality and improving outcomes in AMI patients. Your preparation should include being able to recognize these presentations and manage them effectively with the appropriate drugs and interventions. For your internal medicine exam, understanding the comprehensive treatment strategy for acute coronary syndrome, ACS, with persistent ST segment elevation is crucial. Here's a summary highlighting the key pharmacological and procedural interventions used in management. Treatment of acute coronary syndrome with persistent ST segment elevation. 1. Initial care. Admit patient to a cardiac care unit. Continuous monitoring for rapid identification and management of complications. Establish IV access, essential for the administration of medications and fluids. 2. Pharmacological treatment. Aspirin. Immediate administration reduces coronary reocclusion by inhibiting platelet aggregation. Clopidogrel adds to the antiplatelet effect of aspirin, essential in dual antiplatelet therapy. DAP. For patients undergoing percutaneous coronary intervention, PCI, continuing for at least 30 days post-bare metal stent and 12 months post-drug-eluting stent. Beta blockers, such as metoprolol, used to reduce myocardial oxygen demand and the risk of arrhythmias. ACE inhibitors improve survival post-MI by reducing myocardial remodeling and preventing heart failure. Statins. Atorvastatin 80 milligrams started immediately to stabilize plaques and manage cholesterol. Oxygen, administered to potentially limit ischemic myocardial injury. Nitrates, such as nitroglycerin, used for vasodilation to increase coronary blood supply and decrease myocardial oxygen demand. Morphine sulfate provides pain relief and venodilation, reducing myocardial oxygen demand. Anticoagulants, low molecular weight heparin, e.g. enoxaparin, preferred over unfractionated heparin to prevent further thrombus formation. 3. Revascularization, percutaneous coronary intervention, PCI, the preferred method, especially for patients with contraindications to thrombolytic therapy, aiming to perform within 90 minutes of hospital arrival. Thrombolytic therapy, indicated for patients who present within 6 hours of symptom onset and are not candidates for PCI. Alteplase is preferred due to better outcomes, with alternatives like streptokinase, tenecteplase, retaplase, lanoteplase, and urokinase available. Coronary artery bypass grafting, CABG, recommended for patients with severe multivessel disease or complex coronary anatomy, particularly when PCI is not suitable. Key points. The goal is to rapidly restore coronary blood flow, reduce myocardial injury, and prevent complications such as heart failure and arrhythmias. Treatment is tailored based on the timing of presentation, patient-specific factors, and the presence of contraindications to specific therapies. Understanding these therapeutic strategies and when to apply them is essential for effective management of patients with ACS in clinical practice, which will be a critical component of your exam knowledge. For your internal medicine exam, having a clear understanding of the treatment strategies for atrial fibrillation AFib, particularly focusing on acute and chronic scenarios as well as specific drug choices, is essential. Here's a summary tailored to these aspects. Treatment of atrial fibrillation. Acute AFib 1. Hemodynamically unstable patients. Immediate electrical cardioversion. This is the first-line treatment to quickly restore sinus rhythm and stabilize the patient. 2. Hemodynamically stable patients. Rate control, beta blockers, e.g., metoprolol, are preferred to slow the heart rate to 60 to 100 BPM. Calcium channel blockers, e.g., diltiazem, are an alternative if beta blockers are contraindicated. Digoxin is considered if there's left ventricular systolic dysfunction, providing rate control without affecting contractility. Cardioversion to sinus rhythm. Electrical cardioversion is preferred and should be attempted after achieving rate control. Pharmacologic cardioversion may be used if electrical is not feasible or fails, utilizing drugs like ibutylide, procainamide, flecainide, sotalol, or amiodarone. Anticoagulation, necessary to prevent stroke if AFib has been present for more than 48 hours or duration is unknown. Anticoagulate with warfarin, INR 2,3, for 3 weeks before and 4 weeks after cardioversion, or start IV heparin immediately if a transesophageal echocardiogram TE shows no thrombus, and perform cardioversion within 24 hours. Chronic AFib, rate control, continue with beta blockers or calcium channel blockers. Anticoagulation, for patients under 60 with lone AFib and no other cardiovascular risk factors, aspirin may be adequate. For all others, warfarin is the standard for chronic anticoagulation. Newer anticoagulants like dabigatran, rivaroxaban, and apixaban may be used depending on the patient's risk profile and preferences. Advanced interventions. Catheter ablation, considered for patients with recurrent symptomatic AFib not controlled by medication. This procedure targets ectopic beats originating primarily from the pulmonary veins. Key points. Electrical cardioversion is critical for unstable patients or stable patients where immediate rhythm control is desired. Pharmacologic rate control is first line in stable patients with beta blockers and calcium channel blockers as primary agents. Anticoagulation is essential to mitigate the risk of thromboembolic events, especially surrounding the period of cardioversion. Catheter ablation is a potential curative intervention for those with recurrent AFib not responsive to medical therapy. Understanding these treatment strategies, the indications for their use, and the specific medications involved will be vital for managing patients effectively and for your success in the internal medicine exam. For your internal medicine exam, it's important to understand the management of narrow QRS complex tachycardias. Here's a concise summary with the specific drug names and treatments for each condition. Management of narrow QRS complex tachycardias. 1. Sinus tachycardia, beta blockers. First-line treatment to reduce heart rate and manage symptoms. Catheter ablation for patients unresponsive to medication aimed at repairing the sinus node. 2. Paroxysmal supraventricular tachycardia, PSVT, vagal maneuvers. First attempt to terminate PSVT via stimulation of the vagus nerve to delay AV conduction. IV adenosine rapidly terminates SVT by decreasing sinoatrial and AV nodal activity. Calcium channel blockers. IV verapamil can be used if adenosine is ineffective and left ventricular function is normal. Beta blockers. IV esmolol as an alternative to adenosine or calcium channel blockers. These cardioversion employed if pharmacologic measures fail or the patient is hemodynamically unstable. 3. Atrial flutter, managed similarly to AFib with rate control, anticoagulation, and possibly cardioversion or ablation. 4. Atrial fibrillation, AFib. Refer to detailed AFib management strategies previously discussed. 5. Multifocal atrial tachycardia, MAC. Underlying disease treatment. Focus on treating associated conditions like lung disease, improving oxygenation and ventilation. Medications, calcium channel blockers, such as diltiazem, used if LV function is preserved. Beta blockers for rate control if LV function is preserved. Digoxin, especially if LV function is not preserved. Antiarrhythmic drugs, IV amiodarone, flecainide, or propafenone may be options depending on LV function. Electrical cardioversion, not effective for MAT and is not recommended. Summary points. Beta blockers and calcium channel blockers are common first-line agents for rate control across various narrow QRS tachycardias. Adenosine is the drug of choice for acute termination of PSVT. Digoxin is used when ventricular function is impaired or as a secondary choice for rate control. Catheter ablation is a non-pharmacological option for certain cases where medical therapy is insufficient. Management strategies are often determined by hemodynamic stability, LV function, and the presence of underlying diseases. Understanding the different presentations and treatments of these tachyarrhythmias will be crucial for the cardiology section of your internal medicine exam.